FDA is requiring that 2 drugs used to help people stop smoking carry new warnings about the risk of serious neuropsychiatric effects. The drugs are Chantix, which is varenicline, and Zyban, which is bupropion. The same warnings will be required for other bupropion products such as Wellbutrin, which are used to treat depression and seasonal affective disorder.
FDA's analysis of adverse event reports shows that when neuropsychiatric symptoms occur, they usually develop during drug treatment, but the symptoms can also develop after the drug is stopped. Some patients on these drugs who had no history of psychiatric illness experienced suicidal ideation and behavior for the first time. The drugs have also been associated with a worsening of symptoms in patients with pre-existing psychiatric disorders.
Healthcare professionals should advise patients to stop taking Chantix or Zyban and contact a healthcare provider immediately if they experience agitation, hostility, depressed mood, atypical changes in thinking or behavior, suicidal thoughts, or suicidal behavior.
Now for news about several recalls of fentanyl transdermal patches. Some of these patches may have defects that could allow the fentanyl gel to leak out. If the gel touches a patient's or a caregiver's skin, they could risk respiratory depression and possibly death.
Friends, I would like to tell you a story, a very sad story about a painkiller that has been around in the American society since 1957. That is exactly 50 years.
FDA is taking action to reduce the risk of fatal overdoses in patients taking the pain medication propoxyphene, which is an ingredient in drugs such as Darvon and Darvocet. Some European studies have indicated that propoxyphene may be more lethal than other pain medications when it's taken in higher than recommended doses.
32 years after we first asked the Food and Drug Administration to ban Darvon or propoxyphene, and 6 years after the United Kingdom announced that they were going to ban the drug, the Food and Drug Administration has finally, belatedly, taken it off the market. Between the time that the United Kingdom asked for this drug to be taken off the market and now, there have been 120 million prescriptions filled in the United States for the drug, which translates, from our calculations, into 1,000 to 2,000 deaths in this country, avoidable if the Food and Drug Administration had been more careful about the health of the people in this country and less concerned about the health of drug companies making this product. Europe banned these drugs about 1.5 years ago, so the United States is way behind other countries, and it just has not paid attention to a lot of information. The Food and Drug Administration commissioner back in '78, when we first asked the FDA to ban the drug, is so convinced that the drug is dangerous that he actually joined our petition to ban the drug this time. People need to slowly stop using this drug because it does have some addictive properties. It's not a very good painkiller. Practically anything you use is as good or better than the drug, but it is addictive, so we would urge anyone who's using the drug to slowly cut down their dose, talk to their doctor about replacing it with something that is just as or more effective and much less dangerous.
Representative Stein.
Thank you, Mr. Chairman. I'll be brief. Just very quickly for Dr. Petro, I'm sorry. If you could just explain to me maybe the difference between a patient getting a THC capsule as opposed to smoking marijuana. Is there any difference in the benefit that the patient would receive from that?
Yeah, actually when I had submitted my proposed study to the FDA, at the time I was even an FDA employee in the middle 1970s and working also at the Hershey Medical Center, I planned to use cannabis rather than THC, but the government stated that this essentially would be the sine qua non to prove whether marijuana worked. In other words, if the most, quote, dangerous toxic component of cannabis worked, then you would suggest that marijuana works. So this was in fact a drug that was used. This is much less effective than inhaled cannabis. I'll just give you briefly 2 seconds. If you are a patient that has the nausea of cancer chemotherapy or intractable muscle spasms, you need immediate relief. If you inhale marijuana, the marijuana is in the brain, in these receptors, not in the area that's the dangerous part of the brain, but in the pain-sensitive areas, within 1 circulation time. That's 17 seconds. You reach the maximum drug level in the brain within 7 minutes after inhaled marijuana. With this, it's between 1 and 2 hours. So it's much more effective in certain pain syndromes where there's a sudden onset of what we call lightning pains to have a treatment that's fast and effective. And I also might remind you that in comparison to the opioids reach peak level in periods of half an hour to 2 hours. And in fact, in Europe right now, there's a major concern because of the passive euthanasia problem. Sick patients with cancer and ALS and other neurologic diseases are actually sequestering, they're secreting drugs like Vicodin, etc., to use to commit suicide. There's no way you can commit suicide by inhaling marijuana.
Thank you for your testimony. Thank you.
We're now in the offices of Dr. Donald Taskin, noted pulmonary researcher here at the UCLA School of Medicine. Thank you very much for joining us today, Doctor.
It's my pleasure.
The show, of course, is Marijuana, Compassion, and Common Sense, and we'd like to talk to you about, you've done years of research with marijuana in relation to pulmonary systems. Is that correct?
That's right. Would you like me to tell you?
Yeah, tell us a little bit about
about my research and the results. I'm primarily interested in the health effects of marijuana, with the focus on potential adverse or harmful effects of marijuana rather than beneficial effects. Therefore, what I have to say may have some negativity to it in terms of the potential medicinal applications of marijuana use. So my first experiment was to see what happens to the size, the caliber of the airways after smoking marijuana compared to smoking tobacco. And I was amazed that after smoking marijuana, the airways actually opened up, dilated, in contrast to the effect of tobacco. So and we found that there was a much higher proportion of marijuana smokers, but marijuana only without tobacco, who complained of cough on most days for at least 3 months out of the year for 2 or more years. That's the definition of chronic bronchitis. They also brought up sputum. They wheezed on more than 21 days a year. They didn't have any increased shortness of breath compared to control. So immediately we could say from this study that marijuana smoking, heavy, regular marijuana smoking, is associated with chronic bronchitis. We failed to find any positive association between marijuana, even heavy marijuana use, which we define as more than 10 joint years. Even if you look at more than 60 joint years, a joint a day, times the number of joints smoked, we could not see an association, nor did we find any potentiation of the carcinogenic effect of tobacco, nor did we find any reduction in the risk from tobacco. So there was no interaction with tobacco. If anything, the risks were a little bit less than 1, but not significantly so. And I don't think there really is protection, because if there were, one would see a dose-response relationship. That is, the heavier smokers would show more protection than the lighter smokers, or lower odds ratio, if you will, and they didn't show that. So I think it's really essentially a negative study. We failed to find any positive association with cancer. Now, what does that mean? Does that really mean there absolutely is no association? We don't know that. I mean, it is possible that people with the appropriate genetic makeup who are particularly susceptible to lung cancer, if they're exposed to any carcinogens, whether they be in marijuana smoke or in some other substance they're exposed to, might be a greater risk. We can't exclude that possibility, but our data are unable to answer that question.
Well, now, the so-called protective effect, the group that there was some, actually the people who smoked marijuana had a somewhat less development of lung cancer than the people who didn't.
On the average, but not significantly,
Yes,
so
but,
not statistically significant.
But yet, the people who are smoking marijuana are being exposed to these carcinogens, and for some reason, they're not developing the cancers that they should be, because, like tobacco smokers do, who are exposed to the same thing. So there's some. I know Dr. Abrams, I know, asked you at the conference, is there a protective effect? And you responded that was not an unreasonable hypothesis. What did you mean by that?
It's still an hypothesis.
Yeah.
We know that there are, in some studies, anti-tumoral effects of THC. Not in all. In other studies show a pro-tumoral effect.
Mm-hmm.
And these are studies that were carried out in a variety of animal models and cell cultures. And what they show is that when you expose these animals or cells to THC, there is a reduction in tumor growth, the rate of tumor growth, and also a reduction in spread, metastases. And three mechanisms have been proposed. One is an anti-proliferative effect of THC, impairment, let's say, in protein synthesis, etc. One is a so-called anti-angiogenic effect. In order for a tumor to grow and spread, it has to develop a blood supply. And it appears that THC inhibits the development of that blood supply. And another is something called a pro-apoptotic effect. That means an enhancement of early programmed cell deaths, so that cells that age ought to die off early in order to prevent them from undergoing malignant change as they age. So some studies have shown a pro-apoptotic effect. Other studies have shown an anti-apoptotic effect. There are other animal studies that show an anti-tumoral effect. So you could hypothesize that perhaps what's really operative in these cases is an anti-tumoral effect that counterbalances the pro-carcinogenic effect of the carcinogens. Mm-hmm. So that's a possibility. That doesn't mean if you smoke you're going to be less likely to develop it. It means if you smoke, you may be counteracting the cancer-promoting effects of the smoke. But that's purely hypothetical. That's why I said it's not an unreasonable hypothesis.
Well, Doctor, I've got a lot more questions to ask you, but today's interview we've run out, so we're going to close this one down, and we'll bring you on for our next show next week.
Okay.